Hi, I'm Maddie. I'm a physiotherapy student, and today me and my friend Betty will be going through some of the joints of the neck. So to start, I'm going to be going through the atlanto-occipital joint, which is basically the joint between the base of our skull and our first cervical vertebrae. So this is the occiput, this is the base of our skull. It has a couple different features that play into the joint, and then this is our first cervical vertebrae. So it just attaches here, and it also articulates or joins up with the base of our skull. It also joins up with our second cervical vertebrae, which has its own little features. It has this little dens that sits in the arch of our first cervical vertebrae and articulates or joins up with the occiput through that. So I'll be going through some of the distinct parts of the atlanto-occipital joint first. So we're going to look at our occiput. This is from the posterior view or the back view. So if we bring this back, it sits in the front, and we have our spinous processes that sit at the back. This is looking at our occiput. This has our little occipital condyles. They're convex, so those play into how our joints move. And then it has this big foramen magnum, which is our big hole where our spinal cord enters into our skull, okay? And then this is our first cervical vertebrae. It's part of the atlanto part of the atlanto-occipital joint. So it has its own little condyles on either side, and these ones are concave. So they join up with the little condyles on the bottom of the skull, and they form the atlanto-occipital joint. Next, we'll be going through some of the ligaments that contribute to the atlanto-occipital joint, okay? So our first one is our alar ligament. It attaches from the dens, which is actually part of our C2 vertebrae, but contributes to part of our atlanto-occipital joint because it attaches to the front of the foramen magnum. So what the alar ligament does is it limits how far we can side flex, so bring our ear to our shoulder, and contributes to the rotation of how our head moves. So we also have the tectoral membrane, which is the continuation of the posterior longitudinal ligament, which is basically just the ligament at the back of our spine. And it attaches from C2, so again, our axis, to the anterior foramen magnum. So that's very tough tissue, and it limits atlanto-occipital extension, so how far we can get back this way, okay? So now we'll talk about the biomechanics of the atlanto-occipital joint. So it has a capsular pattern, which basically means that extension and side flexion are equally limited. So we have this capsule that kind of informs between the two, and we can't get as much extension and side flexion. We have 2 degrees of freedom, so it's a flexion extension degree of freedom and side flexion, okay? So when we have flexion, it occurs around a transverse axis in a sagittal plane. Basically, the axis goes right through your ears, and we're gonna rotate around that axis. And the sagittal plane is because it cuts our body into sides. So the osteokinematics is that the skull will rock forward, so it's gonna come forward off of the C1. Our arthrokinematics is basically just how the bony parts of the joint are working together. So as we flex forward, our occipital condyles, so these little convex parts, we're gonna glide in the posterior side. So it's gonna roll forward and then glide posteriorly because it is the convex side. The convex-concave rule basically means that when the convex side, so that's the occiput in this one, is going to move, it's going to roll or glide in the opposite direction of the movement. If the concave side was moving, it would roll or glide in the same direction. So because it's the occiput moving on the C1, we're going to get the movement in the opposite direction, okay? So with extension, it's going to occur around the same axis, so right through our external acoustic medius or our ears, and we're going to come backwards and we're going to roll posterior but glide anterior because it's moving in the opposite direction again. So our last and most important movement is our side flexion and rotation. So our side flexion and rotation is actually a coupled movement. So basically our side flexion axis, which side flexion is just bringing our ear to our shoulder, our axis is coming right through our nose. And for rotation, which is like shoulder checking, our axis is coming right through the top of our head and just anterior or just forward from that foramen magnum, okay? So our osteokinematics are just when our head is gonna side flex and then rotate the opposite way. So if I'm gonna side flex to the right, I'm actually going to rotate my head to the left. So my nose is going left. If I side flex to the left, my nose is actually going to go right. So the same thing with these. If we side flex to our left, our nose or the front of our skull is going to go to the right. And if we side flex to the right, we're going to have our nose go to the left. Okay? So our arthrokinematics is just how the bones are moving compared to each other. So our occipital condyles are the things on the bottom again. They're going to translate opposite direction to side flexion. So if we're side flexing to the left, they're going to translate to the right. Okay? And then we'll get anterior glide of the condyle on the opposite side of the direction of the rotation. So if we're rotating, side flexing to the left, rotating to the right, we're going to get anterior or forward movement of the condyle on the left side and posterior movement or movement backwards on the right side. Because that makes sense, because if we're side flexing to the right and rotating, this condyle has to come forward and this condyle has to come back in order for that to happen. This is actually limited by the alar ligament because it actually tries to stop you from just doing side flexion and causes some of that rotation in order to get some more movement, okay? So we have a couple ranges of motion values. So our normal for flexion is about 3.5 degrees. Our extension is 21 degrees. If our right side flexion is 5.4 degrees, our left side flexion is just a little bit more at 5.6. Our right rotation is 6.6 and our left rotation is 7.9 degrees.
All right, I'll be talking about the atlantoaxial joint, also known as C1 and C2 joint. All right, so now we'll be taking a closer look at the biomechanics. So the C1 and C2 joint is a complex joint made up of 3 synovial joints. So the joint is biconvex, meaning that the inferior facet of C1 and the superior facets of C2 are both convex. The degrees of freedom are 2. So we have, again, flexion, extension, and side flexion coupled with rotation. So for flexion, we have the movement occurring in a sagittal plane. The osteokinematics of flexion for the atlantoaxial joint is that atlas rocks anteriorly with the head. The arthrokinematics, inferior facets of atlas glide anteriorly and inferiorly, just like that. So they glide anteriorly and inferiorly. Okay, so this anterior pivot of C1 on C2 is very minimal because we have what we call the transverse ligament. Here looks something like that. So the anterior pivot is very small because the transverse ligament restricts the movement. If the transverse ligament is damaged, C1 will excessively translate relative to C2, causing a posterior translation of the dens of C2, which can cause a spinal impingement during cervical flexion. So like flexion, the movement of extension occurs in the sagittal plane. The osteokinematics of extension are that the atlas rocks posteriorly with the head, like so. The arthrokinematics, the inferior facets of atlas glide posteriorly and inferiorly. All right, so now we'll be talking about rotation. The movement occurs about a vertical axis through the central dens, and there is about 45 degrees of rotation on either side. So the arthrokinematics for rotation looks something like this. So if I'm rotating to the right, the C1 facets, the inferior facets on the same side of the rotation will slide posteriorly, while the facets on the opposite side will slide anteriorly. The alar ligament is a very important structure when it comes to the rotation of the atlantoaxial joint. So their function is to they act as a resisting factor of excess rotation at the atlantoaxial joints. All right, so now we'll be talking about side flexion, which is coupled with rotation to the opposite side. This is the coupled movement of the joint. So we'll start with the osteokinematics. So when the head side flexes, we'll say it'll side flex to the right. When the head side flexes to the right, The alar ligament on the opposite side, so on the left side, will tighten and result in the rotation of axis, or C2, to the same side of the head tilt. This leaves atlas to rotate to the opposite side, which is why the coupled motion occurs. So with side flexion, there is rotation to the opposite side. So now we'll be talking about the arthrokinematics. For the arthrokinematics, the glide will occur on the same side of the flexion. So the glide of the inferior facet will occur on the same side of the flexion. The atlas may also glide inferiorly, so like this, at the median joint right here, to give the alar ligament some slack in order for the movement not to be restricted. Again, we talked about the alar ligament, but it's going to be an important structure in this coupled movement. So the alar ligament will resist the side flexion. And we also talked about how it contributes to the rotation at the craniovertebral complex.